The abductor hallucis can be the primary muscle right here and can give you not only pain here, but a very tight muscle, and the nerves coming down through this area here can get entrapped. And carpal tunnel we've seen before, where the median nerve is entrapped by the flexor retinaculum. And one thing to remember about the carpal tunnel syndrome is that the pronator teres muscle can be very tight and can irritate and entrap the median nerve at the elbow. So if you have an EMG that has been done to make a diagnosis of carpal tunnel, they need to have checked the transmission rate to see if there's any slowing at the elbow as well as the wrist, since the problem can also be up at the pronator teres entrapping the median nerve, but you also have to remember that there are many trigger points in the upper back and neck and in the upper arm, which can mimic the pain in the wrist and forearm. And just one other pearl that you might want as far as carpal tunnel is concerned: always look at the first dorsal interosseous muscle, as this muscle can give you all sorts of strange kind of neurologic findings and pain patterns in the hand. And there's no really specific pattern that you can say everybody will demonstrate, but you should always check it. And if it's irritated, inactivate it with the laser, and then you will see the symptoms change and the findings, your clinical findings, change. And then you know that the patient doesn't have an uncomplicated carpal tunnel. Okay, we've finished the main part of our webinar, and we'd like to see if there are any questions from any of the people who are online that they'd like to have answered specifically that I didn't cover. I tried to anticipate as many of the clinical questions that might come up, since I treat patients with all of these problems fairly frequently. Don't be shy. You can enter a question, and I think most people would be interested in it. The entrapment neuropathies are pretty straightforward in that what's important is that you have to remember to look for trigger points in the muscles that can do it. Don't just simply assume that the patient has a neuropathy that you have to treat with medication, because a simple use of the low power laser can in fact resolve it. I might just anticipate a question in that I had a patient who came in several months ago complaining of low back and a carpal tunnel problem. I might add, first of all, that they didn't have a carpal tunnel. They had just the first dorsal interosseous muscle causing all their symptoms in their hand. The other thing is that this same patient turned out to be diabetic and had no sensation from slightly above the ankle, and included their whole foot. And when I inactivated the medial gastrocnemius trigger point and the peroneus longus trigger point, her sensation immediately became normal and has stayed normal for over 2 months. So you can never just accept what is sent to you in the diagnosis. You should evaluate yourself. Here's a Do you primarily aim the laser at the belly of a muscle or at the attachment? What you have to do, first of all, is to look for the trigger points. And when you find them, aim the laser right at the trigger point. That's what you should do initially. If there is a component of a chronic tendinitis, then you can move that's not relieved by the release of the trigger point. Then you go to the tendon and use the laser at the tendon attachment and see if you can inactivate the pain from there. But the key is looking for the trigger point, and they may or may not be in the belly of the muscle. You have to learn those, and you learn them by finding them and by reading one of the references, which I will give you. And once you start doing these things, you won't need to refer to the book at all or even think about it. You will know precisely where these trigger points usually are and look in that area and palpate where you find it precisely. And you will learn how to feel these, and the patient, when they, that Dr. Travell affectionately called the jump sign, when they jump, that's the trigger point. Palpating a trigger point, many of my patients have said that palpating the trigger point is actually more painful than injecting it, because the injection pain only lasts a few seconds, whereas the trigger point palpation can last several minutes. Once you activate that trigger point and push on it, it stays painful until you inactivate it frequently. So you don't just aim at the belly. It's not like a Botox injection. You have to look for and find and then aim the laser at the trigger point. I think that's a very good question, because people who aren't familiar with it need to be aware that that's the case. Any other questions? Okay, then I think we're done. Let me just show you the references. Here's one that's really important. If anybody's going to treat chronic pain, they need to read this book cover to cover. That will take you quite a while. And Volume 1 was published in 1983. The first edition, the second edition was published in 1999. Volume 2, which is the lower body. This Volume 1 is the upper body. Volume 2 is the lower body. That was published in 1992. And you might think, well, it's out of date. It isn't. It's consistently one of the most widely purchased non-student textbooks in the world. Cold lasers and pain management is in Practical Pain Management in September, October 2004. I wrote a brief review, guest editorial in Practical Pain Management as to how my practice was changing using the ML830 laser. And I think that sort of would give you a very good background if you haven't had a lot of experience with it or even used it at this point. And the other article that I wrote here was published in this last spring in Fibromyalgia Aware, which is the publication of the National Fibromyalgia Association. And it too is available through the website. It's an article basically describing my protocol for treating fibromyalgia and noting the differences between fibromyalgia and myofascial pain and the similarities. And if you're going to be treating both of those conditions, I think it's a really worthwhile 3 pages to take a look at. If you have any specific questions or suggestions, email me at this address, Dr. Filner at mymla30.com. Or if you want to call to leave a message or to have me call you back to discuss a case or a problem, you can call 888-789-0745. Thank you very much for participating today, and we hope you learned a lot and enjoyed the webinar.